keep going here. Let's say you have a patient who comes in post-operatively, their liver is not appearing to be working properly. You have to sort of know how you're going to evaluate somebody like this, or what are you going to do. The first thing you're going to look at is look at all the drugs that the patient was administered, including all the analgesics, antibiotics, over-the-counter preparations, including the anesthetic agents that were given to that patient. Sometimes giving people vasopressin, epinephrine, Levophed, which are catecholamines or vasoconstrictors, can cause the splanchnic circulation to become so vasoconstricted that you don't get adequate blood flow, and the liver can actually die from hepatocyte oxygenation problems. So that can be pretty lethal. So you got to check all those things first. Check for sources of sepsis, which is another thing. Then you want to look at the possibility for exogenous bilirubin load, okay, which means that the person could have blood that they're hemorrhaging into. So transfusions of blood contain approximately 250 milligrams of bilirubin, and that can significantly increase bilirubin levels in an individual, especially if it's older blood. The greater the age of the transfused blood, the more likely that it's breaking down. So the bilirubin load can be pretty high in that kind of person. Patients with normal hepatic function were given large amounts of blood without an appreciable increase in bilirubin, but this response may be different in patients with coexisting liver disease. So sometimes you can see it in somebody who's cirrhotic, but in other patients that are normal, giving them blood transfusions and have no problems. Make sure that you rule out occult hematomas, so make sure that you don't have a retroperitoneal hematoma, things like that. And then the other thing you want to look for is rule out for hemolysis is taking place, and you want to look for a retic count, see if that's elevating. Your preoperative records, look for evidence of hypotension, arterial hypoxemia, hypoventilation, and hypovolemia. And other things that you've got to consider is extrahepatic problems such as low cardiac output states like congestive heart failure, respiratory failure where you don't get adequate oxygenation, PEs, and renal insufficiency. And then consider also some benign postoperative intrahepatic cholecystasis associated with extensive surgery and massive blood transfusions. And then the last one you need to think about is immune-mediated hepatotoxicity from the actual anesthetics. So what do you see? Okay, what happens if you have abnormal LFTs? Okay, if you see intrahepatic damage, okay, you see an elevation in your SGOT, which is and your SGPT, which is very similar to it's the same thing as the ASE and the ALT. So those are indicating to you that you have liver damage that's intrahepatic. If you have post-hepatic damage, then the alphas become elevated, and that's usually an indication that you have stones in place, and that's one you have to be more concerned about. So this is and the also thing that you see is an increase in conjugated bilirubin more so. Yeah. Okay. Chronic hepatitis eventually forms from many different diseases, including viral hepatitis. You may also have an autoimmune hepatitis that develops in some people. People like scleroderma may actually develop chronic hepatitis as well. Patients that exposure to drugs that they continue taking will cause chronic hepatitis. That's why they need to be discontinued. A lot of the statins can cause this. So that's why we have to watch liver function tests very closely on those individuals until we identify that they don't have a problem, because you can't know who is going to be more susceptible because it's a genetic predisposition again. You have Wilson's disease, which we'll talk about a little bit later, alpha-1 antitrypsin deficiency, primary biliary cirrhosis, primary sclerosing cholangitis, and hemochromatosis are all forms of chronic hepatitis. Chronic viral hepatitis, the first one we'll talk about, it's hepatitis B virus. There's a 5% world incidence of converting into viral hepatitis as chronic. And it's more likely if you have it in a young person. HCV, which is hepatitis C, is 1.8% incidence of cures in the United States. So these people they have hepatitis C and they end up giving people food. They can cause people to get hepatitis C. They don't even know they have it. So it's pretty dangerous in that respect. 85% of acute infections become chronic, and that's one that's hepatitis C is one of those scary ones because that one has the most highest incidence of developing hepatocellular carcinoma. Your non-infectious are the drugs induced, can be like things like methyl-dopa, trazodone. I don't expect you to memorize this, but just know that there's many different drugs that you can have chronic hepatitis from, And if you see somebody come in with that, you really need to look at the book and pull out all the different drugs that can cause hepatitis and then basically eliminate them. You can't keep that person on it. Wilson's disease is what's called hepatolenticular degeneration. It's a disease process where the person cannot properly get rid of copper. Okay? And that person will get Kaiser-Fleischer in the eyes. They actually get copper deposition in the eyes. They get this kind of pretty color around the actual pupil. The copper eventually concentrates in high enough concentrations that it causes liver damage that's permanent. Okay? You also have a disease process called alpha-1 antitrypsin deficiency. That's usually we've seen in people that are developing early COPD because it's a breakdown product. It helps break down some of the toxins from the smoking. And if you have alpha-1 antitrypsin deficiency, you're more likely to get liver involvement as well. Primary biliary cirrhosis means that there's something happening to the biliary tract, okay, where it begins to become sclerosing, okay, which eventually becomes sclerosing cholangitis. But primary biliary cirrhosis means that the actual biliary tubes begin to disappear. Okay? It's a devastating complication. It's usually an autoimmune phenomena, and we don't really understand the primary source, but eventually that person needs a liver transplant. Okay? Primary sclerosing cholangitis is the actual common bile duct and portions of that duct going outwards that eventually scar down, and you get, again, a chronic hepatitis from that. The most common form of cirrhosis in the United States is actually due to self-induced. It's due to alcohol. So alcoholic cirrhosis is a big issue. The big issue about alcoholic cirrhosis is that it depends on the person's diet. If you look at alcoholics that don't have cirrhosis, they usually have intact families where somebody's constantly feeding them 2 or 3 meals a day. So the nutritional effect is basically they're maintaining that, even though they're alcoholics. The ones that usually get cirrhosis are the ones that are by themselves. They forget to eat anymore, and they begin to just drink. Okay, and that's when the acceleration takes place and causes the liver damage to become extensive. As you can see, this is a normal-looking liver, and this is what the actual liver looks like with a cirrhotic. It's all scarred, and it basically doesn't allow blood flow to go through it properly. Portal circulation becomes a big issue. You can see here this is normal, and this eventually is what a patient looks like with cirrhosis. You can also get cirrhosis from other things, such as post-necrotic cirrhosis from viral infections, autoimmune or cryptogenic, which means we don't know the cause of it is. So we have a primary identifying injury, and then the actual cells become damaged, and they form scar inside the liver. Primary biliary cirrhosis, which I talked to you about before, is usually it's an autoimmune process that attacks the biliary tract and causes cirrhosis as well, and all these other ones as well. If you look at primary biliary cirrhosis, it's usually seen in women more so. Okay, it's an autoimmune phenomenon. It's usually seen in women between the ages of 30 to 50 years of age, and you see a lot of osteoporosis developing in these individuals. A lot of these people have associated autoimmune problems such as Crest syndrome, scleroderma, things like Sjogren's disease, or what's it called, Raynaud's disease as well, as you see. So you got to be concerned about autoimmune IgM. That's what's causing this. You can see how the biliary, this is the normal bile ducts, how they eventually form into this common bile duct. Well, with the autoimmune phenomena, these bile ducts are actually attacked, and they literally begin to disappear. So now the bile can't get rid of, the body can't get rid of it, and you get very high levels of unconjugated bilirubin, or even portions of conjugated bilirubin, depending on how extensive you can't get rid of any of the bili. Hemochromatosis, if you look at the way this is worded, okay, hema means blood, chroma means iron, usually. So it's an iron deposition inside the liver cells. Okay, it's found in persons that have an inability to basically remove the iron in their body. You see it much more common in men than women. It eventually develops in primary liver cancer, and it's seen in patients with congestive heart failure and diabetes. And the way we treat it is actually very simple. We just phlebotomize them. Okay? The reason women don't get this disease as much is because they have menstrual cycles, so as a consequence their hemoglobin levels are a little bit lower than men's, so they don't get as much accumulation of the iron in the liver and causes permanent damage. This is Wilson's disease. Wilson's disease is an autosomal recessive defective in copper binding, which I showed you before. You can see this is what I was talking to you about, the Kleiser-Fleischer rings. Okay, it's a brown crescent ring in the periphery of the cornea. It kind of looks kind of pretty if you think about it. It kind of jumps out at you. Have you ever seen some of the Kleiser-Fleischer rings? It's sort of, when you look at them, you sort of say, "There's something not right." Okay, and then if you're perceptive, you start looking at what you're seeing, and you'll pick it up. Okay, and believe it or not, you can actually make a huge difference in that person's life. These people come in usually crazy. They come in really acting odd. They do some really odd things. They'll talk weird things. And it's because the copper is beginning to actually begin affecting their brain function. It begins to affect the liver, so it's not able to remove toxins. So these people develop like an encephalopathy. But it's actually very easy to treat. It's just treated with chelation therapy. And actually it's pretty simple to do. We can actually do it with two ways. We can either do it by urinary excretion, or a lot of times we're doing via plasmapheresis. Okay, so they plasmapherese the copper off, and the person's symptoms go away. You know that they're getting better because the Kleiser-Fleischer ring will get smaller but never go away. So they always have that kind of appearance to their pupil. This is what a cirrhotic liver looks like. This, of course, somebody did not survive this. Okay, but you can see it's nodular. One of the things that I always look at when I'm doing a case when the gallbladder is I immediately look when the surgeon is looking at the liver to make sure that I don't have cirrhosis in place. Because if I have cirrhosis in place, then I'm going to be much more attentive to my positive pressure, make sure that I'm getting hypotensive during the case. I don't want to get this person to have an inadequate perfusion to the liver in this situation. These people are much more sensitive to getting hepatocellular damage from either hypotension or elevations in peak inspiratory pressures. This is how nasty it can become. This is pretty ugly, as you can see, worse from bad to worse. Eventually it becomes one single nodule, and you can imagine the portal circulation literally can't get through there anymore, and these people die of usually hemorrhaging to death. Okay? Most of these people have huge varices, usually in the esophagus and the stomach, and then they eventually perforate through the actual esophageal wall or the gastric wall, and the person begins to massively vomit blood. Okay? How many people have seen a Sagenstein-Blakemore tube? Not many. Okay, we used to put these tubes quite often, and it was a nightmare because you literally had to try to stop the bleeding from taking place. They would aspirate blood a lot of times. You'd intubate them at that point, and then they would be very, very sick. Because when you intubate them and put them on positive pressure ventilation, what's going to happen to the liver? Even worse shape. Okay, and then you're going to add more positive pressure, so portal circulation pressure goes up. So it gets even worse. So usually they would die on us from hemorrhaging to death. We'd give them transfusion after transfusion to try to keep them going, and we a lot of times would end up failing. So what they came up with is a procedure that changed the way people die. What it costs you pretty much for each unit of blood is 250 cc's per unit. On the average, a patient coming in for this kind of disease, and there would be anywhere between 10 to 20 units of blood. That's a pretty significant change. Okay, so instead they came up with a procedure called TIPS. Okay, and I'll show you that in a minute. This is a cirrhotic liver on the CT scan. It's got the granular pattern. Okay, this is where the gallbladder is at. Okay, and this is the histological changes of cirrhosis. You can see the scarification that occurs on the outside here. The liver inflammation, liver necrosis eventually leads to hepatic coma and encephalopathy because you can't get rid of toxins, and that's one way. Or the other way is the portal hypertension leads to the variceal hemorrhaging, and you also get ascites forming pretty extensively. So you get portal hypertension. This is a complication. It's varices, massive hemorrhage. Treatment, it may necessitate what we call the portal systemic shunt, which is what we call the TIPS procedure now. Cirrhosis has increased resistance to portal circulation, leads to portal hypertension, splenic vasodilation, and it leads to ascites, and it causes arterial underfilling, of course, and it causes your lack of activation of vasoconstrictors. It eventually leads to expansion of plasma volume, delusional hyponatremia, and hepatorenal syndromes are much higher in risk in these individuals. This is what I was trying to show you before. By telling you verbally what happens to portal circulation, you see how it backs up, and this person develops varices inside the stomach and inside the esophagus. Okay, we actually ban these now. We didn't have that capability before. We'll actually take an endoscopy scope, go down into the esophagus. We have a specialized device that looks like a little cup that's attached to the end of the scope, and we suction the varices into the cup. And then we have a rubber band that then flips onto it and attaches to the varices. So we can actually cause the varices to become sclerosed, okay, just like we do for hemorrhoid. Okay? But it's done internally, which is kind of very useful in these individuals, and now you sclerose that vein off, and hopefully they'll stop hemorrhaging. The next procedure that's basically was done is this portal systemic shunt. Okay, and what you're trying to do is you're going to bypass the liver. Okay, so TIPS procedure means transjugular intrahepatic portal systemic shunt. Okay, in the old days, the way it was done, it was a nightmare. Okay, we had to do this with an open procedure where we actually took these people to the operating room. We'd open up the abdomen wide open, and then we would put a vascular shunt into the portal vein, and then hook it up into the inferior vena cava. Does that sound easy? Imagine you got somebody who's got bleeding complications and has got coagulation factors that are not working properly. You have a grossly dilated portal vein, which is paper thin, and now you're trying to put sutures into it to make it hold the actual vascular shunt. It just sounds like a bad idea to me, okay? And it was, okay? We end up doing these cases. They usually were 8 to 10 hours long, and a lot of times you were giving maybe 30 to 40 units of blood, and a lot of times didn't make a difference. So instead they came up with something that was less invasive, where you don't have to go through the skin at all, in the sense of you don't have to go through the abdomen. You actually go through the vein in the neck. Okay? So we literally just put a little catheter in the neck vein, and we pass it down into the inferior vena cava. Okay? Through that little catheter, then they put a needle through it. Okay? And we literally spear through the liver. So we're stabbing the liver inside. But why is it okay? Why is it the person doesn't hemorrhage to death? The liver is an organ that's solid, and it's encapsulated by a very thick capsule. Okay? So when you're putting this needle through, you're trying to find the portal veins. Okay? And the portal veins are greatly distended. So usually, eventually, after about 2 or 3 strikes, you end up hitting another vein, which is in that case is a portal vein. If you get too aggressive, which I've seen a few times, you will push the catheter. This is done under radiology where they can see this, but sometimes if you get too aggressive, they'll push it right through and they'll go right through the hepatic capsule. Then it becomes a nightmare. Okay? But as long as they stay within the hepatic capsule, the chance of having a complication goes down. Okay, once they get into the portal vein, okay, they shoot dye in it so they see that it's a portal vein. Then they pass a wire through. Okay, so now the wire is sitting in the portal vein and the inferior vena cava. Okay, then they put in a stent over the wire. Okay, and then they inflate the stent, and now you have a stent that connects the portal vein to the inferior vena cava. Okay, does that make sense? So all that damming effect that you have because of all the cirrhosis now gets bypassed. And now what happens is the portal vein begins to collapse back down to a normal size. And the varices that are there are going to get a lot smaller. Does it go away? No, it doesn't ever go away. But it goes down to a less pressured situation, and you stop hemorrhaging a lot of times. Now, what do you think the bad side of this is? The bad side to this is that you can't get rid of the toxins that your portal circulation is picking up. So if this person takes in a big steak as part of his, let's say he decides that, I feel great and I'm going to go out and have a Outback dinner and I'm going to sit and have a huge steak. I'm not going to have the 26-ounce porterhouse, okay? I don't think they have one, but he sits there and eats this big steak. That steak has got a lot of protein in it. Now the liver is not conjugating it and not getting rid of it, so it goes right to the brain and the person gets encephalopathic. Okay? And the person will go unconscious usually within 24 hours. A lot of times they never wake up from it, and they end up dying from encephalopathic coma. Okay? A lot of times you just support them for a while, then they'll get better. But a lot of times at that point, family are just saying, you know, it's these DNRs, it's only going to get worse. And so what you just did is you just changed the way the person dies. Instead of dying hemorrhaging to death, which is pretty awful, instead you're going into dying by going to sleep in a coma, and then you die quietly. Complications of cirrhosis is collaterals, cause azygos and amazygos veins, cause gastroesophageal varices. The ascites is also a pretty significant problem. It's usually due to the production of albumin becomes significantly impaired. Portal hypertension, sodium retention also becomes an issue with this disease process. Spontaneous bacterial peritonitis, because now instead of the liver getting rid of the bacteria, now the portal veins start extruding bacteria into the peritoneum, and you get peritoneal peritonitis. If you get a hepatorenal syndrome that actually develops, it usually is fatal. It's about a 98% mortality rate. And adding positive pressure to somebody who has ascites is really risky, okay? Because you impair renal perfusion, okay? And you affect portal vein circulation. So you get a double whammy effect. So you'll lose both the liver and the kidney in this process. And usually that has a 100% mortality rate for these individuals. Hyperdynamic circulation is something that's very commonly seen with these individuals. Because part of the reason is that two reasons. One is they're intravascularly depleted. Okay, so what the heart has to do is it basically has to crank up its cardiac output. Okay, intravascular they're depleted, but extravascular, in the interstitial space, peritoneal space, they have lots of fluid. So these people are actually very heavy in fluid, but it's not intravascular. So the way the body compensates for this effect is to increase cardiac output to sort of tolerate this intravascular depletion state. Okay? You get also peripheral and splenic vasodilation that takes place that's inappropriate. Okay? You can see at times, it depends on what part of the disease process, increased intravascular fluid volume, especially during surgery, that's inappropriate for this individual. But most of the time, in real life, you see a decreased intravascular fluid volume. Okay? You do get hypoviscosity due to development of anemia, and these people do develop a much higher incidence of AV fistulas, including in the lung, where they actually develop them as well. One of the things that you go on and look for is anybody who has cirrhosis that you might have to do a transplant on. You got to check for the AV, that they maybe have AV malformations in their lungs. Okay? This leads to a very significant arterial hypoxemia, where you're getting right to left shunts. These are big AV fistulas, and diaphragmatic excursion also becomes limited because the liver becomes so enlarged. Hypoglycemia may become an issue as well. You have depleted glycogen, which is part of the liver. Remember, liver stores glycogen as the emergency supply of glucose. So hypoglycemia becomes an issue in these people. And development of duodenal ulcers is actually fairly common. Gallstones are also common, impaired immune defense. Hepatic encephalopathy from portal systemic shunting, which is the PIPS. It's usually from ammonium or nitrogenous waste products of hepatic metabolism. It causes obtundation. Asterixis, you know what asterixis is?
Flopping tremor.
Okay, flopping tremor. The best way to actually pick up somebody with asterixis is tell them to put their hands up like this. If they're looking at it, they'll be able to hold it. Close their hands start doing this. Okay? That's how you know they have asterixis. Okay? The thing is you'll smell their breath. You know if somebody has liver damage by smelling their breath. Okay? When you're taking care of them as a doctor or a nurse, once you smell that smell, you'll never forget it. It smells like ammonia. Okay? It just jumps out at you. Okay? It's hard for me to explain to you, but it smells a little bit like ammonia, and it's usually a bad indication because that person usually is in the process of going to the next step, which is they become obtunded at that point, and they also develop the encephalopathy. Steatosis means that the liver begins not to be able to get rid of the actual fat uptake, and this is what you see as ascites. Okay? Pretty significant degree of ascites. This can be pretty difficult to treat. What we do is a lot of times is we'll drain the ascites to help make the person more comfortable. The reason this is dangerous to you is what does it do to FRC? This is not a pregnant woman. Okay. What's that? Decreases your FRC. So these people are at much higher risk for aspiration, and they're also at higher risk for developing desaturation and induction. Okay. So you got to be really careful and pre-oxygenate these people appropriately. So pathophysiology of ascites is several things. The most common that we're talking about right now is from cirrhosis is from portal hypertension. It causes an increase in capillary filtration pressure and eventually leads to ascites. If you have hepatocyte failure, it causes decreases in albumin synthesis, which and also alters metabolism of renin and aldosterone, which becomes elevated, which increases your effective plasma volume, and that leads to increases levels of ascites. All that fluid does not stay intravascular for long, though. It begins to be extruded into the ascites, so these people become intravascularly depleted in the long term. Caput medusa is another picture I just wanted to show you. It's called the head of a Medusa's head. Caput means the head of Medusa. And Medusa's tail basically talks about snakes in her head. So it's not a very good picture, but if you look at the skin, you'll see these kind of snake-like, the actual skin has got the veins become grossly dilated in the stomach. Okay, so when you look at the stomach, it's all bluish tinged on its surface. That usually means very severe forms of portal hypertension. What I'll do is I'll stop here and we'll stop next week on this, and then we'll. Okay, thank you.